Plumas County Public Health Agency, growing healthy communities.
So I'm Liz Jones, and I'm a health education consultant with the California Department of Public Health and our Safe and Active Communities branch. And I work with Dr. Wirtz here on our prescription overdose. No, I always get to tell you, prescription drug overdose prevention initiative. I always forget one of our letters. We go by PDOP, which is much easier for me to go by acronyms. And I'm just going to let Steve say a little bit about himself before we get started.
Well, I'm the chief of our injury and injury surveillance and epi section, and work on some of these projects to try to help communities handle the opioid crisis. And I'm really impressed and glad to be here today, and hope that we can provide some useful information to you. And more important to us, we're trying to hope that we find out from you some things that will help us do our jobs better. So I look forward to talking with you.
So I'm going to get us started just really quickly. First off, if you have any questions as we're rambling on, please don't hesitate to raise your hand and let us know. Steve and I are hoping for this to be as interactive as possible. We don't want to just stand here and talk at you. We would like to talk with you. So that being said, I'm going to go ahead and get us started. We're talking about Prevention 201, and this is really California's approach to the opioid epidemic. And Steve is actually going to get us started. Hopefully this no, this way? One of these? It was just working like 2 seconds ago. There we go. So just a very quick overview of what we're going to be talking about. But our first part is the opioid burden in California. And this is all data, so I let Steve do this part.
Yes.
Okay.
So many of you have probably heard about our the California Department of Public Health has the California Opioid Surveillance Dashboard, and I'm just going to highlight a couple things from that. I don't think we're going to be able to run the dashboard live, but I want you to know that it is also available on your phones. You can search, if you just Google California Opioid Dashboard, it will be generally the first thing that comes up. This is, if this is a pointer, I'm not sure. That's one of the titles for it. It also, so mainly I would just Google it for the opioid dashboard for California, and you'll get to it. So what it starts with is this general overview of the opioid crisis in California. Nearly 2,000 deaths. One of the things we've been watching, and we'll show you this a little bit more, is the role that fentanyl is playing in the opioid crisis, and I think you all will have some experience here in the rural areas where the burden is even higher than in some of our other areas throughout the state. Opioid overdoses also end up in the hospital or the ED, the emergency departments, and there's total about 8,000 emergency departments a year for that, both emergency and hospital. And then I think we start with the issue of the opioid crisis being one that has been aggravated over the last decade by the health profession itself, as you all know, with the concepts of over-prescribing for pain. Pain management is an important function and remains an important function that needs to happen, but what happened is that pain medicines began to be used more and more for chronic pain, and the amount of prescribing has continued to go up until recently. And I just want to point out that number over there, the 21.7 million prescriptions are distributed, dispensed in California each year. And if you take just 12 and above year olds, that is about 1 prescription per person in the state of California. And I'm going to show you some good news about that. That's way more than we think we need. It used to be much, much lower than that, and then rose during the time when opioid prescribing by medical profession was blossoming into what became more and more of a problem for chronic pain, where opioid medicines are not necessarily that effective in doing that. And in the process, it has the obvious downsides of leading to addiction to the opioid medicines, and then potentially to other substances that would go along with that. And so what I'm going to show you, as you well know from your own experiences, that this is a map of California showing the overall opioid death rates, and it shows that the rural counties that we're sitting in have the highest rates of opioid overdose deaths than the rest of the state. Now, one of the problems around that is because you have a relatively smaller population, resources don't come your way, and so even though you have this high proportion, other parts of the state have higher numbers and obviously in general get more resources than the rural areas that as you well know. But we have at the state sort of focused on this reality that, that these communities don't have access to treatment in the same levels that others do, and to the resources that can contribute to preventing drug use in the beginning and drug addiction as you go along. So we've seen that the rural communities have substantial problems, and our programs have tried to put a major focus on that through support for coalitions and other things that Liz will talk about. But there's our starting point for what the nature of the problem is. For the rates, highest in the northern regions, but for the numbers, obviously you still have your LAs and San Diegos that have a high number of people who are also facing addiction and overdose problems. What I wanted to sort of say is that this is a little hard to tell about the death rates over time, but the main thing I'm going to come over here and say is that we peaked again around in 2015, but we've seen somewhat of a dropping off of overall opioid deaths, which is a good thing. That's been driven primarily by what's been happening with prescribing. And there has been an awareness that the health profession has been very much responsible for massively increasing the opioid use of opioid medications, and therefore the amount of prescriptions happening. Obviously, we know that the pharmaceutical companies were marketing these products as non-dangerous and as requirement for doctors to take care of people's pain. And the message was, you know, if someone's in pain, the doctor should do everything possible to make sure they don't have any pain. And here's a drug that gets rid of that pain and there's no downside, is the message that was being taught in medical schools as well as marketed by pharmaceutical companies through one-on-one marketing that we now sort of call academic detailing version of. But this shows you that since the peaks in like 2011, both opioid prescriptions in blue and the morphine millimeter equivalents, or a measure of dosage, have been going down substantially. You know, some update, but substantially down. And that's where that number of 21.7 million prescriptions, it actually was over here in 2011 or so, it was like 26 million. You know, and here it's about 24 million. So the number of prescriptions are going down, and the dosage of those prescriptions, or sort of the number of pills that go along with prescription, have been going down. That's the sign that some of the work that has been done by the medical professions, the regulatory boards, the CURES program, the work that we've been doing around educating, changing policy, putting out the CDC guidelines, all of that's been focused on physicians and pharmacists and on their practices. So that has begun to bend the curve on the amount of opioid medications that are out there. But at 21.7, it's still million. It's still way above where it needs to be. And this is only one of the natures of the problem. This has been going on for a while. This has also translated, so it shows that these issues are preventable in some ways. This is also translated into a drop in prescription overdose deaths. So those in which there is a prescription medicine have also dropped fairly significantly over the last few years. That's all a good sign that things can get better, and that we know something about what was triggering prescription opioid overdoses. Now, all of this data, I want you all know that there's almost never an overdose that's a single drug. So polydrug use and polydrug overdoses is central. As we know, opioids join with benzoids or with alcohol to cause often is what triggers a particular overdose. So these are measures of just saying we've got a piece of the puzzle that we're working on in the right direction. But what's been happening, and as you well know, is that we've had an increase in the heroin-related deaths. Okay, now the numbers, you know, I'm not going to go into this. The numbers here are smaller than those numbers we had before, but they're still showing a massive increase in heroin deaths. And so we're seeing a switch from the nature of the epidemic moving from being, and I say there's 4 phases. People talk about 3 phases to the opioid epidemic, but I really try to focus on 4. That is, people said, we've had a heroin and opioid issue forever. That's phase 1, and that's where we've been hidden, and there's been no services, and people have been stigmatized, and they're isolated. And that is the condition we had until the opioid crisis hit, where that was much more medically induced from the healthcare profession and was caused and brought in a different population of people who had addiction, more white, more middle class kind of clients. And that has opened up an opportunity for us. The downside, obviously, is that it's caused a lot of deaths, but the only upside is it's opened up opportunities for us to address addiction in a way that the people who've been doing harm reduction and so on have been doing it forever. And that is to treat people with dignity and understand that it's a disease and that it's a difficult situation to deal with addiction. If we're not careful, though, as we move back into our heroin, and then, as you all know, the other piece is with fentanyl. Fentanyl has gone up from less than 100 in 2000 deaths in 2014 to 373 in 2017. We've already seen potentially between, we're still looking at what's the final number, but between 100 and 140 fentanyl deaths this first quarter of 2018. So we're expecting this to continue to go up. So as you see, we've had progress on the prescription side, but we are now moving back into having heroin and fentanyl analogs and other pieces playing a major role in causing, triggering the overdoses. And what I would argue that we have to be careful on is that if this becomes simply defined as an illicit addiction problem, then we're going to go back into a level of stigma that will keep us from caring for people the way that this opportunity allows us to do. So one of the things the department is trying to do is build as much infrastructure, change social norms, get people to understand what addiction is, build capacity to have treatment and so on, so that it's in place when this problem, whether it's opioid prescriptions or whether it's heroin or fentanyl, will have services. Yes, please.
Yeah, hi Steve, thanks. One other risk we have of becoming the illicit, thought to be an illicit problem is, as somebody that's in front of physicians trying to change their prescribing behavior a lot, they can start saying, oh, this isn't a prescription drug problem at all, it's an illicit drug problem. So do we have data that talk about the percentage of those illicit drug users that have moved from prescription drugs? Do we have newer data on that? Because we all kind of, right, there was numbers from books that said 80%, or do we have anything on that?
Right. We know that most, so there's an issue of numbers. Many people, 21, millions of people take opioid drugs for pain management. Relatively, very few of them get addicted and move toward other drugs. But people who use heroin are like 40 times more likely to have used opioid medications. So we know there's a good tie there. I don't have good new data on that because it's a little hard to get the sequence of who started when. And I'll just say one thing about the sequence, but first, please, you join.
Oh, sure. Yeah, I didn't want to interrupt.
No, that's fine.
We, in Plumas County and in our region, we were looking for the same information. We have these a high level of prescribing, and we also know that people are injecting drugs, and we also know people are overdosing, and so so when we launched our naloxone program, part of the data collection that we did initially was asked a few questions about the drugs that people first started injecting when they started injecting drugs. And the majority, I don't have the exact percentage, but it might have been like 70 to 80% of our naloxone clients were injecting their pills first. And so we were able to use that data to help the community understand the justification for further harm reduction programs. And so but we really needed to get that local data, and it's not a huge database, but it really helped us understand. But we were looking at the state level too for that, and I just don't think it's there yet.
Yeah, no, I think you're pointing out the perfect thing is that you really do need to work in your local communities and see what's happening there. Go ahead.
Yeah, so along the same lines, it's a constant battle to try to make sure that clinicians believe that their prescribing is affecting this at all. And one of the difficulties are the curves that you're showing that show death rates, total death rates, still going up, where prescribing in our county has been going down since 2010. And so they say, well, how come we're not seeing a result from that now? And the only answer I have, and I would take as much help as I can get, is that people get started in the pipeline and there's a lag time. There is a delay between starting opioid use, becoming dependent, moving to more risky behaviors, and death. But that's me telling a story, that's not data. And if there's any data to help with that, there is.
So for that, we do have good data, and that would be what I would have done if it would be easy to use the internet here today. But I'll just remind you that if you go to the website, one of the things I would look at is the age pattern of those deaths, for example, or the ED visits. So that website, you go to Plumas. The problem obviously is small numbers and so on. We can talk about that, but I tend to do two things with it. I tend to use it first. I look at the state numbers because that gives you the clear overall picture. Doesn't mean that's what's happening in Plumas, but it does give you the overall picture that shows that, for example, if you look at the age breakdown, as we know, with both heroin and prescription opioid addiction, it tends to be a lifetime kind of thing. That the deaths tend to occur from 50 on up for even for heroin users. However, and you can look at that. So that's the first thing you can do is you can look at the age breakdown on the website. I would do it statewide first, and then your local communities because of the small numbers issue. But I think you'll see the general same pattern that there's obviously some youth, but the older age groups have the peak of deaths. Now, if you look at fentanyl deaths, though, you will see a fundamentally different pattern that scares me. And that is that it's shifted. That the people dying of fentanyl are in the 21 to 35 age, so much younger group. And that's why we call that last slide is that fentanyl is a game changer. It happens so quickly that people don't even have a time to get addicted fully. That they don't live through the horrible experiences of addiction. They take their pills or they shoot up something that has an unknown amount of fentanyl in it, and they overdose right then, and they may be recovered or they may die. So there are two patterns happening, I would argue. One is that people are, as prescriptions are shrunk, and as people put limits on it, or they feel like there's limits, and as there's not the solutions that are supposed to go along with those limits, namely, who's doing the acupuncture, and who's doing the yoga, and who's doing the meditation, and who's doing the non-opioid medications. When those are present also, and when the doctors know when they don't fire their patients, it's too hard, I'm being told I can't use opioids, I just don't want to deal with any of these patients anymore, and they drop their patients, that's what leads to them going to other substances, not so much that they're being cut down slowly and managed in an appropriate way and maybe put on buprenorphine or so on. So it's how doctors change their practices and how patients deal with that, not that they are changing. If that makes sense in a way. So if a doctor irresponsibly says, I'm told not to prescribe, and I don't know how to handle these people that are addicted, I'm just going to get rid of these patients, and I'm going to say, I'm not going to give you any more. You're using, I found some cocaine in your blood, so or urine, so I'm not going to take you anymore. That's what puts patients at risk to become moved to another way, because they are potentially addicted to these heavy levels, high levels of regular opioid medication, and then they're told that they got to stop, and the doctor doesn't know how to handle that. They then are likely to look around for pills in someone else's cabinets, and then on the street, and then potentially other ways of ingesting and other ways of getting it. The heroin is cheap. We have a market system here, right? And the marketers for heroin are very smart, and they know when there's a market, and they know how to take over the market by reducing the price. So heroin is much cheaper than the OxyContin or other pills you might get. So we have this multiple factors leading to both the addiction crisis and the change in the nature of it, moving toward these, to the heroin and the fentanyl. So please.
Just a question about fentanyl. I guess carbophenol, even more toxic version of it.
Yeah.
From what we keep hearing from our addicts is they don't know what's out there.
Right.
And so you see that thing skyrocketing and it coming in from China, most of it. How are we looking at tackling that? Because it's quality of product and it's inconsistency in the dosage. Telling addicts don't do street drugs doesn't work. They're going to continue to go to their dealer, and sometimes their dealer is getting a different product that happens to have fentanyl in or carfentanil, and they overdose. So yeah, so I don't know. Well, I've also heard of a subgroup of that where we have addicts actually looking for fentanyl, but that's the hardcore addicts. By accidental overdose ones where they think they're getting a certain dose and it's way beyond. What approach are they taking to address that?
I would argue that the best answer, first of all, because it's a legal market, then we don't have the regular things. We can't talk about, guidelines and standards and so on. So that's where harm reduction becomes the central player in this. And what you can do, here's where a coalition needs to have several players together working very closely together. You do need your law enforcement, you do need your coroner or medical examiner, and you need your harm reduction people that are working with your addicts and other. And what you need to have is enough trust so that maybe when the first person overdoses and everyone has naloxone so that person doesn't die, that person, then you find out that that was actually fentanyl or some analog of fentanyl. And the word then gets out through those networks of harm reduction, of the coroner being on your team. And, and you could have it be in your paper. You could have, yesterday 2 people overdosed from a new drug in town. Be careful. It looks like it was fentanyl. So that's where I think bringing this in as a community solution becomes critical. Because we can't stop, we should be working at the state and, in other places to stop the fentanyl coming in, but we're not that successful with that. So the answer's got to be that the community recognizes that harm reduction people can actually talk to. I know in San Francisco, Rachel's not here, but in San Francisco, I know that when a fentanyl outbreak happened, they went and they could end up talking to the dealer and say, what are you doing? This is, now, as I think you were indicating, the dealer, there's hardcore addiction. People are looking for highs. That one of the problems with heroin and other things is that, you don't get your highs. So people are looking for even higher. But you're right. So the message that happens in harm reduction, like in New York City, is they're going out and saying, this product is out there, it's unregulated, it's mixed badly, and you don't know whether your dose is going to be the enough grains of fentanyl that you're dead, versus someone else is saying, this is no different than usual. So I don't know if that helps, and if there's any other clarity, that please.
Well, and this is one question. Isn't there a way to test your...
Yes, the fentanyl strips.
And that's some things that for harm reduction, some of the writing that I've done is some of the people that use street drugs that keep some fentanyl testing supplies on hand, so they know if their heroin is mixed with
as well as enough.
And then they know whether or not they want to use it, because they know whether it's street heroin.
It's not perfect, but it's certainly a good proactive effort to have fentanyl strips. And my understanding is the Office of AIDS at the state can help your harm reduction services get those fentanyl strips. So if you think that you're getting fentanyl coming in, then that's the thing you want to, that's part of the message is, so before you take, you know, test this with your strips.
So
I'm not
seeing earrings with fentanyl test strips on.
I don't think they're that widely available yet, but that's certainly, that's where working with your harm reduction people, and instead of saying the issue is only simply let's go arrest anyone that's using because they may have been the ones that brought it in or something. That's, you know, you've got to understand that the problem is more complex, and we're not going to arrest our ways out of the problem. It's, you know, it's a part of it. We certainly don't want people bringing in fentanyl with, you know, with the idea of selling it for profit at the cost of human lives. So that's not an acceptable solution either. Did you have one more comment?
Just adding to the fentanyl test strip discussion, you know, they are available through the clearinghouse, through the California State Office of AIDS. Our newly launched syringe program has fentanyl test strips that we will give out to clients. And as you're talking about, you know, the public health community or the law enforcement community spreading the word, if we do find out that there is fentanyl in the drug supply, I think even faster, and this is exactly what you're getting at, Steve, is that, you know, if we give those test strips to people who are using the drugs, they're all very connected with each other, and the message will travel much quicker to the people using drugs, and we'll have a better chance of saving more lives and keeping people safe, keeping the, you know, giving people the tools so that they can spread the information as well.
So we've heard several parts of it. You know, the naloxone availability has got to be there. Then the fentanyl strips have got to be there, and then you have to have a community that's able to get the word out. And I would argue that part of this goal is really to make sure that we do understand that people who were injured and end up on opioid medications may, in fact, then be the ones that that they may be like you and me is what we have to get in the community, so that there isn't this stigma of that, you know, they did it to themselves and why did we spend any resources on this and so on. That's what we have to change. And if we don't do that quickly during this, quote, opioid crisis of prescriptions, we're going to be back into the world of us and them, and drug users being labeled and separated and not provided the resources to help them both deal with their addictions and move on and understand how many of us have made it through in terms of recovery and so on. So that's the goal. That's what a community coalition can do, is help change the dialogue in the community and say, these people are, you know, so-and-so's son, and you know, the father of this person, and you know, someone used to be a nurse, and so on. These are people that lived in our community, live in our community, and they are deserving of this kind of an approach for us with a harm reduction approach and with the resources necessary to make that happen in the community. And you are the voices that sort of translate that into reality for our community. And you have local papers that can tell that story and work with, you know, all of these partners to do that. So anyway, that's my soapbox to the.
So speaking of voices, so Humboldt County and Lake County are getting the opportunity to meet with legislation in September. So I would ask, as you do your presentation today, if you feel that there's a key point that we really need to take to the table, if you could point it out to us, and that would be helpful for us to be able to present in a way that legislation can hear us and hear where we need the help, what our challenges are, and what our successes are as well.
Well, that's great to hear, and you probably are going to hopefully learn from your community here, all these communities here. One thing I'll just point out is that the state legislature passed, whatever it was, 2 years ago now, a one-time naloxone distribution grant program, which went through our office, and we were able to put out 70,000 naloxone kits throughout the state, and that's a lot. That was $3 million worth or so. But that was a one-time program. So the legislature passed a law to allow that to happen one time, and I think there's still a need for naloxone. So I think that I can say that very clearly. Now, Liz is going to run through sort of the full range of what we do with the department. We've had one of the things that's happened, the opioid crisis is the only topic in the country, I would argue, in general, overstating, that there is bipartisan support for, right? So both Republicans and Democrats have been supporting getting more money out to treatment and to changing practices in the healthcare systems. And that's a great thing in a way, because we had law and order vision that, you know, that drug use was crime, and that the only way to handle it was through law enforcement. I think we've had a change when people in the legislature realized that that this was affecting our whole communities, and so money has come down more rapidly, and so we've had the luxury of having money to build out this program some, and Liz will tell you a little bit about this. And we have our partners in the Department of Healthcare Services who are also getting a lot of money through SAMHSA for treatment and so on. They're getting some money for naloxone. But I'm thinking California needs an ongoing way of having naloxone in the community. And same with fentanyl, and same with making sure that treatment facilities are available. The hub and spoke system that Department of Healthcare Services is developing, and I'm hoping to learn what's happening in your community around MAT treatment through hubs and spokes. But that program is also limited funding. It may continue from the federal government, but it's at this point only grant period by grant period. So I'll stop with that. I know Liz won't have enough time to go through everything, but we really mainly want to hear from you as well. So we'll go through this, and again, stop us if you have questions as we go.
And I wanted to say just quickly, I know some of you have already accessed the Office of AIDS and the fentanyl test strips, but if anyone else here is interested in that, Matt Curtis was actually our moderator this morning in that session, and he would be a good person to talk to you about that if you're interested in accessing for your county. So we also want to make sure you're awake here, and so we cut off parts of the words, you know, to make it a little bit more interactive and difficult for you, and make sure you're paying attention. But basically, this is our statewide multi-pronged approach for the opioid epidemic. And so there are 7 pieces. And since you can't actually, I wasn't going to read them out, but now that I see you can't completely read them, I will just say really quickly what they are. So we're convening a statewide opioid safety work group. We have a lot of work around safe prescribing policies and practices. Part of that is an academic detailing program, and I'm excited to see actually quite a few of our detailers in the room today. Building local community capacity, accessing medication-assisted treatment, naloxone distribution, public education, and being data informed throughout all of the work that we do. So I'm going to go ahead. Oh, that's backwards. I guess it's this way now. And I'm just going to start just talking about briefly our statewide opioid safety work group. So this was started a few years ago by our state California Department of Public Health Director and State Health Officer, Dr. Karen Smith. And we have now about 25 member agencies and over 40 state and non-state organizations that participate. We have a few of the logos here of those that participate in this group. The main idea of this group was really to bring together our different state and non-state partners to break down those silos that we have in government work originally, and then to start branching out to some of those other partners in the state that were doing really great work to kind of collaborate and pull all those strings together to have a larger impact on the work for opioids in the state. And make sure I go the right way. One big piece of that I wanted to highlight today, and I know this is maybe a little bit blurry for y'all to see, but one big piece of that is that in the fall, just the past fall in 2017, the work group created the Opioid Policy Framework. And I want you to note that in most of these sections, there are pieces around harm reduction. And that, I think, is a really big step for our state. And just that thoughtfulness in each of these categories. So prevent is really around preventing new starts on opioids. Manage is talking more around policies for pain management alternatives. Treatment is making sure that we have more access to medication-assisted treatment. And then, of course, stopping overdose deaths. Any questions about anything? Okay. So another piece of our statewide opioid safety work group is that we have task forces. We used to have 5 task forces, but our integrated healthcare policy task force has kind of gone away since the work group itself created this policy framework that I just spoke about. So now we really concentrate in 4 areas with our task forces, and that's our treatment task force. I believe both of our co-chairs for that task force are at this convening. That would be James Gasper and Alessandra Ross. And that really is around access to medication-assisted treatment. They just added a new objective for the coming year where they're going to try to get more low-threshold buprenorphine access for the state and more naloxone distribution throughout the state. We originally started looking in rural communities for naloxone distribution, but there's just, as Steve was saying, a recognition that all of California needs more access and more regular access.
Liz, can I jump in here? So both James and Alessandra were really instrumental in providing some input into the hub and spoke design, trying to make sure it did reach rural areas and went to as wide a network of harm reduction folks as possible. They also worked with the California Healthcare Foundation on has anyone seen the Urban Institute's treatment gap website application? So it really does take by California, the counties, and looks at how many people are, through survey data, how many people may well be addicted or need treatment for opioid addiction or SUD. And then it looks at how many people are registered as ex-waiver prescribers and so on, and it calculates a gap. And it, so for Plumas, it might say, you have 3,000 people that need treatment, you have 150 people being served, and so you have a gap of 2,850 people. So if you can Google that also under Urban Institute, California treatment gap, opioid treatment gap, and it's just a very useful tool also potentially for legislators to look at. So I would recommend that you look at that ahead of time and have each county have your county estimates for what the treatment gap is, and that should lead to a recognition of some gaps in services.
Great, thank you. And then we have our maternal neonatal task force, and this is really serving as an advisory board for our work group and also for the state on best practices around maternal neonatal opioid issues, especially around neonatal abstinence syndrome.
And can we ask anyone working with pregnant women, and both in treatment facilities and or in healthcare systems?
I know Lindsay is.
Okay. So anything you want to say about your experience with both working with women, in contraceptive time periods and pregnant women around care for treatment, medication-assisted treatment, and or the NAS?
We're very new in our MAP program. We really had no intentions of serving pregnant women with our MAP program. We currently are, and we have once before, and we will see how it goes. We're not really set up to serve neonates with NES, and I know that there's new things, and I listen to news research on treating those infants like babies instead of putting them in a NICU and giving them scheduled medications and doing that sort of thing, which really makes sense because when you take a baby home, you take it home and you treat it like a baby. You don't stick it in an incubator and not touch it for 4 hours at a time and then go back and feed it at a scheduled time. So it makes sense, but we're a really small facility. It's difficult to make changes. Setting up the MAP program was a difficult battle, so I don't really know where we're going with this one. It's going to be difficult to see what happens. I don't know that we are going to deliver this. We might end up, referring this mom out to another facility to deliver, but we're very early on in the pregnancy right now. We did have one delivery where she was on Suboxone.
Oh, good. Ahead of time. I think there were 3 question. So did you have a comment first?
No.
Okay, so let's go in the back first.
I just wanted to say I work in Northern Data, and we are a MPH program. I just started late April, so I don't know a lot about our statistics and things going on. But we do work with a lot of pregnancies. We've had quite a few babies born. I can't speak completely on it, but I just wanted to offer you a resource as far as more information and how that works for us. Lisa Lee, my supervisor, is here. I would highly suggest talking to her.
Yeah.
She's a firm believer of MPH pregnancy. I don't actually work with the girls a whole lot. I do a lot more transportation, doctor appointments, things like that. So I can't speak a whole lot. Much
It's
further
really not a good time for her to take her off, you know, like
Yeah.
she really wants off and we're really, I
That's
strongly
true.
suggested not to.
That's
Our problem is that
everything
we're a
I
high
think.
Medi-Cal population, so we can't necessarily go to Nevada, which is
Correct.
easier because it's an easier commute to Nevada than it is to, you know, a different facility. But certainly a good resource, for sure.
Yeah, I did.
What was
Another
your
comment
boss's
there,
name?
yeah.
Lisa Lee.
Thank you.
I would just
She's the
suggest
secretary.
we pay very close attention to this problem because it's, as there are more and more MAP programs, there's going to be more and more pregnant women. And so the
Yep.
struggles that you're going through,
Yes.
you should be noting each, I mean, it's going to be a very important lesson going forward, and now is the time to start to pay attention to that, because it's just, all these MAP programs are just hitting.
Right, and that's one of the things we argued is that we wanted to make sure that MAP program, we work with the Department of Healthcare Services and their, they have a pregnancy group and our MCH people. So this task force really does have some of the experts statewide that are going to be helpful, but we need to hear what it's like on the ground in an MAT program to try to get your doctors to understand that the methadone has to be given differently than for pregnant women over the time of her pregnancy and so on, and that it's much better that they're on Butte when they deliver than that they're not in care and so on. Your comment?
Well, I was just glad to hear you say that the recommendation is to not wean pregnant women off medication, because that's been the recommendation for a long time in the methadone world, and so I'm glad you said that, because that's an important thing to say. In our jurisdiction, we've seen an increase in neonatal abstinence syndrome, as I assume most people have. And I was just speaking with the chief of pediatrics the other day, and I think what's changing in that hospital is that they have a coupler program, and that they're trying to change their protocols to be less aggressive with opioids in the kids, because if it's driven by scores and unfortunately by nurses that are very busy and don't like crying babies, that they feel like they've been over-aggressive in the past. I think there's also some data that shows that if moms are on buprenorphine, that period of time of weaning of the child that's necessary is shorter than if it's with methadone. So just some thoughts from our jurisdiction.
And obviously the syndrome, you know, the symptoms, which are, there's some problems in the screening that we're working on getting better screening, but even the symptoms are less severe and less compelling when someone's already on care. So even recognizing the difference between a person coming in who's untreated on heroin and someone that's under treatment with Bute is fundamentally different. So just good to see that you're talking about this, and that's our goal, is to make sure that this is paying attention to what you're seeing. And so, sorry Liz for, let's go forward. That's only 2 of our work task forces. So.
And I do want to say our task forces are more open, so for our community members, if that's something that you're interested in and you want to hear more, we only meet quarterly. Like I said, we're really just an advisory committee at this time. But if we talk a lot about current research, best practices, there are a lot of people in our task force that are on a lot of different groups like ACOG and things like that that are working on this issue actively. So if you're interested in that, you can always email me. My information will be at the end of this slide, and I actually think it's in there's a sheet in your program that has all the contact information. So happy to get you that information if you're interested. So our other 2 task forces are Communication and Outreach Task Force. It's a bit on an ad hoc schedule right now. This really has been around our statewide education campaign, and so it's sort of in a holding pattern right now until we move a little bit more, which should be very soon with our campaign. I'm getting to that stage.
Okay.
I'm getting to it. And then we have our data gathering and sharing task force, and that really is just about data and gathering and trying to do quicker access to data and quicker sharing of that information.
And just to say on that, that we try to get, if you have EPI people in your county, we have many counties that participate in their EPI, their people work with us on the data part of things. So
we're running short on time, so I really do want to talk about academic detailing because this is my program and I'm really excited about it. And we have quite a few of our detailers in the room, but I will kind of move through these quickly so that we can just sort of highlight the other pieces. But one piece around safer prescribing is academic detailing, and we follow an evidence-based curriculum and program that was designed by the San Francisco Department of Public Health with our partners, Dr. Philip Coffin and Emily Vihar. And basically, the idea around academic detailing is that we stole from the pharmaceutical companies the idea of sitting one-on-one, cornering a physician or dispenser, prescriber dispenser, to talk about, in their case, a product, in our case, opioid stewardship. So we have a lot of prescribers out there and dispensers that I think lack the confidence, not necessarily the knowledge, but they lack the confidence in handling difficult situations in their practice. And academic detailing allows someone who has been trained, so we have done 5 trainings so far, where we train people, either physicians, nurses, nurse practitioners, we've even had health educators that have come, pharmacists, and we train them how to sit down and have these conversations with prescribers and dispensers. And so this basically, they sit down, they work with that physician, they work with that pharmacist on the issues that that particular individual has. So the first question is always, what can I do for you? How can I assist you in your practice? And maybe that physician goes, well, I'm hearing a lot about naloxone, but I don't know how to prescribe that. When do I prescribe that? It seems like a difficult conversation to have with a patient. We're already having a lot of, fighting about their opioid use. I inherited them from somebody else. They're on really high levels. I just don't even know where to start. And then this academic detailer is then there to help them sort of break that down and figure out steps and goals that can help that, pharmacist or that prescriber make some change and progress with that patient. So that's where this curriculum comes in. It has multiple sections that basically give the detailer somewhere to start with that individual that they're detailing. So it covers assessment of pain, function and risk factors, informed consent, pain agreements, but also it goes over cures. A lot of, October, is it 1st or 2nd now? It's going to be required that our prescribers use cures. And so how to use that as a tool with your patients. Indicators for naloxone co-prescription, that's a big one. Managing opioid use disorder, like I said, we have so many prescribers that are inheriting patients with use disorder and they're not sure where to start. And then of course harm reduction strategy. So what are some of the basic things that you can do if everything above there seems like too much and you're just getting started? What are some basic things that you can do with your patients to make their visit more comfortable, more positive, and start moving in that direction? And so we started, most of our academic detailers here are from our local county trainings that we did, which were awesome, and people that were already involved in that community already had that buy-in and wanted to see change. But we realized that there's sort of this whole other area of California that we're missing, and that is our health systems, our payer systems. And so we wanted to expand this effort into those areas to have a larger effect. And so now we have started training health plans throughout California to implement academic detailing within their plan. And so, like I said, so far we've completed 5 trainings, but we've had over 70 attendees trained, 8 distinctive counties, and over 30 health plans and payer systems. And we still have more data that I have not sifted through yet, but we have about 130 completed academic detailing sessions, which I think is pretty fantastic for the fact that the program's only been on for about a year. Any questions on academic detailing before I jump through for the last 5 minutes? So building local capacity, we have our coalitions. Originally, the California Healthcare Foundation started funding coalitions throughout California. We, as the state, jumped in and started to assist in funding. We now fund 15 opioid safety coalitions throughout 19 counties. And we continue to collaborate with the California Healthcare Foundation. They have the accelerator program for coalitions in California that goes beyond the ones that we fund, which is providing technical assistance and training and the VISTA volunteers to help with coordination and collaboration within those coalitions and support them and kind of help them move forward and get started. And I think they actually have a presentation going on right now and a little later today that's more on that. And then, of course, access to medication-assisted treatment. I mentioned our treatment task force is working towards this. And Steve already mentioned a little bit about the California Department of Healthcare Services and the substance use disorder work that they're doing through their grants with SAMHSA. They did recently, the hub and spoke system has been the project that they've been working on over the last year or so. But they did just recently get another $69 million for the next 2 years each year. To continue expansion of those that project. And a big piece of that is about $19.7 million is going to be going towards naloxone, and that really is going to be for the community level. So again, if that's something where you have a harm reduction site or something like that, that would be a great resource to kind of keep an ear out for how that might be distributed.
And just to highlight that that's still only a temporary grant-driven piece, so we need an ongoing supply of that over time, but it should be substantial. And for both the MAT program and the naloxone, you can try to reach out to and continue to talk to the Department of Healthcare Services, Marlise Perez, Matt Curtis, and so on, to take advantage of them to make sure you get your voices heard for what you need here locally.
And Steve had already mentioned about our naloxone grant program and the one-time $3 million funding that went towards distribution in the local health departments. And additionally, we have the statewide naloxone standing order that Dr. Karen Smith wrote into law for June 7th of this year. We have about 37 entities that have downloaded the standing order and are using that for distribution. That's for distribution of naloxone, not for purchase, but if for some, a lot of our departments, local health departments distributed that naloxone, and some organizations didn't have a way to actually hand it out. So the standing order covers for those that want to distribute that naloxone. And lastly but not least, I wanted to mention that we have been working with the Harm Reduction Coalition and Eliza Wheeler. We've provided 6 two-part naloxone distribution trainings, webinars over the last year. And that trained on how to use naloxone, how to recognize an overdose event, and also how to, so that's sort of part 1, and then part 2 was how to implement distribution sites at your local level. And through that collaboration, we also worked with her to create a naloxone training video. And I was hoping that that would be up, but we work in state government, so the process is a little lengthy, but that should be up very soon on our CDPH YouTube page. And it's a great resource if you're in a situation where you need to continuously train people on naloxone and how to use it.
And it's what? It's a 11-minute?
I think, yeah, no longer than 11 minutes. So a really great resource and absolutely free. And we'll have it all over our YouTube channel and also linked on our standing order and naloxone webpage.
And just the other thing, Liz was really in charge of doing these naloxone webinars, and each of them basically had, I don't know, 200, 150, 200 people on them. So she had 6 of those 2-session seminars, and so we reached, maybe nearly 1,000 people on that. And then we think the video is going to help on that as well. So
yeah, we're hoping that will kind of fill the gap a little bit, at least for that first part, since we weren't able to continue.
And where did you say it was going to post?
It will be on our CDPH YouTube page,
Okay.
but it will also be on our naloxone standing order page and our naloxone grant program page, and probably our main PDOC page as well.
And it will go out through the Accelerator network news as well. So we will try to put it out through all the networks that we know so you can see it.
Yeah. And so we're basically out of time, but I really quickly wanted to mention that we have been working on a public education campaign. I know it's rather elusive because we've been talking about it as a state for a long time, but it did finally just get approved. I know y'all can read this, so I won't go through all of this, but the next step is basically figuring out our dissemination plan and hopefully having that figured out soon, and the goal is to have this released sometime in the fall. And the key piece for all of you at the local level that I want you to be aware of is that it will be tailorable to your community. So we plan to use the SAMHSA helpline number as our resource for treatment, but if you have a local number that you would prefer to list or a website or something like that, we can work with our media people and tailor to what makes sense for your community so that it's not just what we think makes sense, because it should be what makes sense for your community. So just wanted to mention that. I think that's sort of it. There was more on data, but I think Steve did a pretty awesome job on data, so I would go ahead and end it there, and just if there's any questions. Yes?
I have one question. So you talked about some funding that was for the next 2 years, and I got a little confused there. I was just wondering if you could run by that again.
That's okay.
Okay, was Hub and Spoke in the beginning? Or?
Right, so and that funding's continuing, I think, for another year for Hub and Spoke system and those activities.
I thought that was supposed to end in April.
It was, but it's a no-cost extension.
Yes, so they're
okay, so that means until the following April?
Right.
Yes.
Okay.
And then this is an additional lump sum of funding, which they're kind of calling the MAT Expansion 2.0. So it's just going to continue to build upon the work they're already doing, but I think new additional activities.
It's a separate grant, though.
Yes, it is. It's a completely different grant.
2.0, okay.
Yes.
And is that available? Can you apply for that now?
You can talk to Marlise about what the process is going to be.
I think the funds are supposed to be released in early October, so we're not even exactly sure all the different types of things they're planning to do or how they plan to roll that out. But like I said, just kind of keep an ear out.
Okay.
I'm sure as soon as she has funds and she's ready to go, it's going to be everywhere because she wants to spend that money. So.
And some of it will be, a good chunk of it is going to be to continue to support and expand hub and spoke kind of approaches.
Okay.
I think that's 2 grants, though, isn't it? One's planning, one's implementation.
No, the Congress isn't acting coherently. Congress is just putting out money. I know that's a shock. Generally, that might be the case. But no, in this case, Congress was just passing to get money out there. So this was for $140 million for a 2-year period to just expand efforts around opioids. Marlise got to ask people in all these areas what they thought they needed. Naloxone was one of those. She pretty much listened to the community and is trying to fund anything that sounded like it was evidence-based and moving toward building infrastructure. Her whole goal, I think, is to build the infrastructure that will be there when these Congress decides to move on to some other topic.
So we had a question.
Yeah, just real quick, you didn't touch on it because you were touching on the SOS work groups. Like you said, one was the integrated healthcare policy, and I just wondered, is that what that?
Right. So that group has kind of sunset as the task force because the actual work group decided to take on that policy framework that I had showed with the 4 quadrants.
Okay.
So
and because of the smart care system. So Smart Care California is a collaborative of Covered California, CalPERS, and Medi-Cal. And so they cover 40% of payments of healthcare in the state. They have focused on saying every provider, every payer, and every provider system should have an opioid safety initiative. And then working with the California Healthcare Foundation, they come up with a checklist for what those changes should be in the healthcare systems. We're actually integrating the academic detailing into that opioid safety initiative effort, saying what's, and I'll make it up, Kaiser or United Care or Partnership, what are they doing to move on this checklist of opioid safety initiative? Academic detailing is one of those pieces that we're trying to get infrastructure or institutionalized into those systems. So we really felt like we didn't have to have a task force that met. Right. When we had the workforce itself was looking at these initiatives, and Smart Care was leading the state with 40% of the services there. So we've taken advantage. We support them is what we're basically doing.
Any other questions? So I just want to reiterate, if anything comes up later, I'm here through tomorrow afternoon. And also, there's my email and my phone number. Either is fine to reach me, and I'd be happy to answer any other questions.
And we've really enjoyed hearing some of your issues, and we want to make sure that you have a way to make sure that we hear it, but not just us, the Marlises and the other harm reduction folks hear your messages. So please keep your voices up. All right, thank you.
Plumas County Public Health Agency, growing healthy communities.